Can everybody hear me without this, without the microphone, or do you want with the microphone?
With.
Okay, with the microphone? Okay. Can everybody see the screen?
Yeah.
Because while you're eating, I'm going to be showing you pictures of skin cancer. So I don't want you to miss anything up there. But the reason I talk about this, and I know some of the faces I saw previously, either here or at the cam when I gave the talk, so it might be the same talk. But if you want to embellish, you have any questions, just feel free to stop me at any time. The reason I give this is because once you get this life-saving care, you go on medications that have risks. And we know that, especially from our kidney transplant patients, not as much in heart transplant patients, but once you go on the medications that you're on, they reduce your immune system, right, by design, and then you have to worry about a few things. You have to worry about maybe the immune system not catching an infectious organism, a bug, getting an infection, or maybe your immune system being toned down a little bit and not catching a skin cancer cell. And I'm going to tell you about skin cancer because the good thing is it's one that you can see, it's one that you can prevent. There are certain precautions you can take, and it's very manageable if you know what to look for. The biggest problem when you're on immunosuppressive medication is if you don't know what to look for and you let something go, that's a problem. If you catch it early, with skin cancer, it's usually fine. So I'm going to hopefully help you figure out how to catch these things early, so at least in the whole list of things that go wrong in all of our lives, skin cancer won't be one of them. Okay? We can go to the next slide. So the thing is that when people go to the doctor for a checkup, the question is, in the back of your mind, okay, they're going to check your blood pressure, your blood sugar, etc. But really, in the back of our mind, the question is, could I have cancer? And when people wonder about that, we have to realize that 1 out of every 2 cancers in general, in the whole population when people go to the doctors, are skin cancers. So you can go to the next. Some of these were questions, and then they'll say fact or something like that, and so on. So just in general, there's 1 million new cases every year. That's a lot, right? We have 300 million people or so. There's 1 million new cases of skin cancer every year, and that means that 1 in 5 people will develop skin cancer in their lifetime. Okay? So then we stratify people according to how much risk they have, and people who are on medicine that suppresses the immune system are in the highest risk group. Okay? And then if you add that, if you have very fair skin, if you've had a lot of sun, and if you have a family history, it adds up. It's additive. Okay, so fair skin, medication that suppresses the immune system, and sunburns. And additionally, it's the sun that you get now. Because every time you get sun, if you get enough to get a tan, what's happening is you're getting damage at the cellular level, which needs to be repaired, and the medication that you go on makes it so that you're less likely to repair that damage. So the reason I give these talks to people who are at a higher risk is because it's usually not a doctor. I know that all of our doctors who take care of you, Dr. Ewald and everybody else, are good at looking at these things, but really, statistically, the people who find skin cancers are you, the patients. 53% of the time the patient found it, then you add 17%, it was a patient's family member saying, look at that spot on your back, and knowing what to look for, and then really saving a life. That happens every day. Then we find it about 25% of the time in general medicine. Next one, please. So this is the main point. Everybody should know how to identify and how to take care of their skin to reduce their chance of getting skin cancer. Next one, please. So that leads me to the main point of the talk. If you catch it early, nobody has to get sick from skin cancer. The times that people get sick from skin cancer or lose their life is when they don't go to the doctor early enough to effect a cure. Okay? So the interesting statistic is that most people, well over 50%, will have a growth on their skin and not go to the doctor for a year. So you have to think in your mind what would be that. Some people don't like going to doctors. Some people say, oh, this is nothing. They'll have a story. A lot of patients come in and they have a story like, oh, I got this when I hit the dishwasher. Or a lot of it is hitting my head and then having something on your head that you think is a sore from hitting your head, but it's not. In general, you have to think that a sore let's say a scab, something that you hit, is going to heal in a week or 2 or 3 or 4. If you're going on week 8, 9, 10, 11, 12, 13, and you still have a sore, that's a sign that it has to be looked at. So each year, about 8,000 people die just from melanoma. That's the mole type of skin cancer, and I'll show you what to look for. And besides having people lose their life to melanoma, skin cancer can cause a lot of other problems, significant pain and deformity. If people don't like pictures of, like surgical pictures, you might want to just look down for a moment. The next one, because you can see a little spot like that on the left where the arrow is pointing. When we cut it out and look under the microscope, it can be that big, and you have to take out the whole skin cancer. So again, the earlier you get something, the better off you'll be to save yourself the skin, the scar, the pain. Okay? Next one. So the whole premise is that you can prevent these, and really, ideally you start when you're young by protecting from too much ultraviolet exposure. That means sun and tanning booths. Okay? So it all adds up. Fishing, going out to the lake, walking the dog, in the car through the windshield, all of that adds up, and that's ultraviolet exposure. Okay? So ideally, we protect our kids, because all of us, are kind of past the age where, we get most of our sun before 18. Next one, please. And if you've ever had 2 severe sunburns before you're 18, it doubles the risk of getting the deadly form of skin cancer. Okay, next please. Now the other thing I would tell you also is that if you've had more than 2 sunburns and then you go on immune suppressive medication, it has the same effect. It probably more than doubles your risk of getting skin cancer. And so prevention going forward is the key. That means sunscreen, shade, hats, protective clothing. So this is a myth. In order for sunlight to cause skin cancer, you must get a sunburn. It's also low level, everyday amount of sun before you get burnt, pain, irritated. Just low level irritation from the sun can also lead to increased risk of skin cancer. Next one. Thank you. I don't think does anybody use tanning booth? I mean, I hope you don't. I don't want to have you raise your hand or anything. But one thing you don't want to do, because is use a tanning bed if you're on immune suppressive medications, and that goes for all your friends too. And I wouldn't let anybody do it because it's really 10 to 15 times the amount of the noonday sun when we tell people to watch themselves. Okay? And we're trying to get legislation passed, but it's impossible here in Missouri, they don't want to do it, to just tell kids who are less than 17 who don't think too much that, hey, if you come in here, you have a higher risk of skin cancer, and getting like their parents to sign. So we have to watch out for that. So again, the ultraviolet is like when you hear people getting radiation for a cancer. It goes in, it damages cells, the cells die. Here, ultraviolet goes in through the skin, and it damages the DNA, and it leads to growth patterns that are not the same as normal tissue, and they just keep growing. And that's how skin cancer develops from the sun. Next one, please. Now, getting back to people who've had transplants on immunosuppressive medication, skin cancer is the most common malignancy in organ transplant patients. So when we worry about our health going forward, being on these medications, skin cancer is the #1 malignancy. And it's something that everybody should know about who's on medications that suppress the immune system. And of all the skin cancers that people get on immunosuppressive medication, so again, I'm talking prednisone, cyclosporin, Prograf, Imuran, azathioprine, etc. Squamous cell carcinoma is the most common. And I'll show you what to look for. It's 65, that's a lot, 65 times more common in transplant patients. Okay? And then warts. These are growths. And this doesn't have to do with fair skin or sun exposure. Has to do with your ability to fight off a very common virus. Warts are also about a number of times much more common in people who are on immune suppressive medication. And the thing you have to realize that the human papillomavirus, the warts, so when people tell you have warts, they increase the risk of skin cancer also. Okay, so we treat warts aggressively in people who've had transplants. Next one, please. So this is what warts look like. They are bumps on the skin, and they have little finger-like projections, and they might have little red dots. That's why they were called seed warts. They're not seeds, they're blood vessels. So any growth that looks kind of velvety and has little projections or spikes on it, that's a wart. And some people say, listen, you'll never get rid of them. I just leave them on my patients. I get rid of them all. There's a much higher risk of skin cancer when you have warts on immunosuppressive medication. So another, a little bump. It doesn't quite fit your normal skin. It's got that velvety, raised appearance to it. And those are warts. So something also to look out for, not just in terms of having something that you could spread or will grow, but something that will increase the risk of skin cancer. So we'll talk about the usual ways that people come in with skin cancer. And it's usually one of three stories. The first one is, I have a changing mole. And somebody told me to come in and look at it. Okay? So a normal mole is a nice, even color like this, from side to side, top to bottom. It's small, less than 1/4 of an inch, less than 6 millimeters, and it has sharp borders. And the number one thing I'll tell you about a normal mole is that it doesn't change. So if somebody has a mole and I say, you're fine, I tell them, but it never should change size, shape, or color. And if it does, it needs to be looked at because that's a signal that the mole might not be a mole, it might be a cancer. Next one, please. So I showed you that mole. This is an actual patient. She said she had it her whole life, and I believe her. And it began to change when she was 32. So, that stuff happens. That's melanoma. So how do I know? You can see the very irregular colors within it. There's 3-4 different colors. It doesn't have an even shape. That has no symmetry. And the colors on the sides, side to side, top to bottom, it's bigger than 6 millimeters. Next one, and that's melanoma. So what I was getting at by describing it is that it was asymmetric. You can't fold it over and it doesn't match side to side. The borders are very irregular, the color's irregular, and it's dynamic, A, B, C, D. And that D, dynamic, is really the most important. If one of your moles is changing size, shape, and color, it should be looked at because these dark moles, brown, black, gray, variations of that are the ones that are life-threatening. Okay, next one, please. This, I have this in there, it's a very sad case. This young lady had this in 2001, and I've seen her every 3 months and then 6 months since then, and she had this cut out, and she's been fine, and I always ask her how you're doing, and I saw her on a Thursday. She said she was absolutely fine going to pick up her kids, and Sunday she had to go to the emergency room for chest pain. It was filled, the melanoma was filled in her chest and in her brain. That's what it looks like, and that's an illustration of how serious these types of things are. Not to be taken lightly, especially if you're on immunosuppressive medication. Okay, so we look in the scalp, we look, everywhere. Under the in people who have darker skin, African American, Asian American, you have to be careful and make sure you notice the hands and the feet, the fingernails and the toenails. That's very, very important because that's a higher incidence of people of African descent or Asian descent. Okay, hands and feet. So again, color irregularity and growing larger with blotches and many different colors. And the ugly duckling sign is when usually people make all moles that look the same, and then there's one that might look funny. That's another thing to get checked out. Okay, one that's bigger, darker, more irregular. And again, that's melanoma. Sometimes they don't look like much of anything. These slides look real. That's fine. No, we can go to the next one. Real kind of bleached out, but this is melanoma too. In fact, both of those are. And he always said they were growing, but you can see they really don't look very irregular. So I just want to have a very heightened sense of awareness that if something looks funny, looks different, might be changing, might be darker, we look at it. Now, another case that doesn't look dramatic. Next one. And here in this light, with this type of slide, you can't even see it. And again, I don't want to scare you and say, look, everything is melanoma, but these are all melanomas. And that's why if you even have a question, you should get it checked, right? Next one, please. Okay, so malignant melanoma, just to recap, asymmetric, border irregularity, color irregularity, dynamic. The incidence is increasing. In general, 1 in 58 men and women will be diagnosed over their lifetime. The highest risk is people who have fair skin, real light colored skin with more sun, over the age of 50. And your survival decreases as it gets thicker, and it gets thicker the longer it's there. So that's what I mean by you can cure it. If you know what to look for, you get it early. Next one, please. You can go to the next one. So, two things I want to say with these last two slides. If your doctor sees something and says you have a mole, it really has to be cut up in its entirety. So the correct way to test for melanoma is not to take a little piece of it and send it to the lab. It's to cut the whole thing out. Okay, just make sure if that's ever the case it's done. And again, you have to look also where the sun doesn't shine. It's not all from the sun. This was a melanoma. They said it was a wart for a long time, and that lump on his foot is a melanoma. They just waited too long. That's one thing. All right, so what are, okay, as you're looking at yourself now, if you look at the things that people call liver spots, the flat little tan spots that all look, those are okay. They're from the sun, they're not cancer, nothing to worry about. Next one. These things, this is a mass of them, but everybody's got one or two of these little warty growths that are called seborrheic keratosis. These are okay too. Most people don't have this many, but if you pick out one or two of these velvety, scaly growths on your back, usually on the chest, arm, those are fine. Next one. And again, these are not skin cancer. That's what they look like, seborrheic keratosis. Okay? Next one, please. All right. But they can look just like it. If there's ever a question, certainly just have it checked out. So that's the changing mole growth. The next growth is somebody says, you know, I have this thing that has been it's kind of shiny. It might look like a scar. It's kind of pearly, and it bleeds, and I don't even feel it. Usually, if something bleeds, it hurts, right? You scratch it. It's a burn, a scrape, whatever. If something's kind of shiny, pearly, enlarging, and they say it just bleeds for no reason, and I don't even feel it, that then is, you go to the next one, basal cell skin cancer. So now we've gone from the mole type of skin cancer, the dark brown black spot, to the one that looks like a shiny pink spot. And you might say, oh, this is just a pimple, this is just a sore of any type. But acne and sores go away in 2 weeks, 3 weeks, 4 weeks. This one's been growing probably for about 8 months to a year, right? So you don't tolerate that for more than 2 months, let's say, a pink shiny spot like that. And that's basal cell skin cancer. Not much higher in transplant patients, but in general, this is the most common human cancer. There's nothing more common than this. It's shiny, pearly, and there's red blood vessels usually seen on top of it, most often in sun-exposed areas, but not always. Next one, please. So here's a benign mole. It has your normal skin color, your normal skin tone and texture, but it is a bump. It doesn't have that shiny, pearly, kind of odd appearance with the blood vessels on it. Next one, please. And that's unlike basal cell skin cancer, which starts out as a shiny little bump, and it just eats away normal tissue. Next one, please. It rarely metastasizes, but it does invade tissue. So again, if you have a spot you thought was acne or a sore and it's not going away, it's bleeding, you still have to get it taken care of because it'll never stop growing. Okay? And it can eventually metastasize. So if you don't treat them, they never stop growing. They get bigger and bigger. They cause ulcers, sores that don't heal. They become infected, and they can eventually spread. Next one, please. Next one. Thanks a lot. So in the types of things that look like basal cell skin cancer, I told you that it's a pearly, shiny little bump. These spots that if you look on your body and they're a little red, they call cherry spots, cherry angiomas, those are fine. Okay? Not related to skin cancer. Next one. And they're not cancer. Can you see that those are red? Okay, so you probably recognize at least one on your body or people that you know with those little red dots. Those are not skin cancer. So I talked to you about a pink shiny spot that is skin cancer that will continue to grow, bleed painlessly. These just stay there and do nothing. They're red, they're harmless, and we don't worry about them. Next one, please. So the one that's more important, I think, to everybody who's got fair skin usually and who's on immunosuppressive medication, transplant patient, no matter what pigment you have in your skin, if you've ever been exposed to warts or had warts, this is the one that's 65 times more common in transplant patients. And they say, you know, doctor, I have a red crusty sore and it's just not going away. Or it might be kind of tannish and crusty. And again, you say, well, I have a sore, it'll go away. But if it's not gone with your special circumstances by 2, 3, 4 weeks, you get it checked out. Because that's what squamous cell skin cancer looks like, the one that's 65 times more common. It's red and crusty. Okay? Next one, please. So it's a red, scaly, crusty, and it's usually big enough that people say, I got a lump on my skin. Or at least a pretty good sized bump. Here's a fully grown squamous cell skin cancer, and it's a red nodule, kind of volcanic. but it doesn't have to be eroded, giving it that volcanic appearance. It can just be crusty on top. But it stays red, it tends to be tender. People say, boy, when I touch that, it really feels uncomfortable. They have a sensation to it. Next one, please. And another one that is quite large, again, a red lump that again has an ulcer and some crust in the middle, and they can be quite aggressive. Next, please. So again, squamous cell skin cancer, to recap, they look just like common sores, acne spots, cysts, but all those things go away in 1 to 2 weeks. Okay? 3 weeks maybe. Give it 4 at most. And if there's still a red lump that somebody was saying, oh, it's just a sore, it's just an acne zit, or whatever else you want to say, then you still got to get checked. That's too long to wait. Okay? Especially for you all. Next one, please. So to recap that, squamous cell carcinoma is a scaly, crusted, sometimes red, sometimes tannish, pink nodule, meaning a growth or like a lump, or a plaque, which means it's just kind of flat and scabbed. It's the most common skin cancer in organ transplant patients. It's on sun-exposed skin, but not always. Because of the wart association, it can be in the groin, it can be down on the foot, it can be anywhere. Okay? But more commonly, it's in sun-exposed areas. They occasionally exhibit very rapid growth, and 8 out of 100 can spread to the lymph node and cause you then to have to get treatment at an oncologist. They're also invasive, meaning they get very deep in the tissue and they destroy that tissue. Next, please. So that's squamous cell carcinoma. Now, again, in people who have fair skin, a lot of sun exposure, they might not notice a lump or a thick bump like this, but you might just notice these little crusty spots that you pick off and it comes back, pick off, it comes back. You look in the mirror, they're kind of red and flaky. Those are considered precancers called actinic keratosis, and it's a precursor to the squamous cell carcinoma that I showed you. Very, very common. Next one, please. And they have this kind of thick, scaly substance on it.